This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Neurosurgical Review, published in 2026. The paper is titled Association of Cerebrovascular Center Volume with Patient Outcomes, and it's a comprehensive look at how institutional and provider case volumes correlate with clinical success across the entire spectrum of cerebrovascular disease.
This is a topic that hits home for all of us in the field, Alara. We often talk about the learning curve or staying sharp, but this study, led by Dr. Stacy Quintero-Wolf and a large multi-institutional team, really codifies the data behind those concepts. It's a review that spans everything from microsurgical aneurysm clipping to mechanical thrombectomy and even neurocritical care.
Exactly. And for our listeners, residents, and fellow attendings, the core message is clear. Modern cerebrovascular and stroke care necessitates comprehensive care by experienced providers in high-volume centers to optimize patient outcomes. The paper starts by addressing a really important point, the role of microsurgery in an increasingly endovascular world.
Right. They mentioned that while trials like ISAT and BRAT favored endovascular therapy, or EVT, for ruptured aneurysms, microsurgical clipping remains an essential component of aneurysm management. They actually cite the 2023 AHA-ASA guidelines for managing aneurysmal subarachnoid hemorrhage, ASA.
Yes, those guidelines are specific. For example, they recommend that for patients with ASAD deemed salvageable, especially those with a depressed level of consciousness due to a large interparenchymal hematoma, microsurgical clipping should be considered early.
And the data they reviewed regarding volume is striking. They found that mortality and patient safety indicator events, or PSI events, are clearly lower at high-volume centers. This applies to both ruptured and unruptured aneurysms. It's not just about the surgeon's hands, it's about the whole system's ability to handle these complex cases.
That's a recurring theme in the paper. When they pivot to cerebrovascular malformations, specifically AVMs, the findings are similar. AVM surgery is famously complex, and the study demonstrates that patients undergoing surgery for these malformations have significantly better outcomes in high-volume centers when treated by high-volume surgeons.
It makes sense. If you're only seeing 1 or 2 AVMs a year, the entire perioperative team, from the scrub tech to the ICU mess, isn't as tuned in to the specific risks and complications as a team that sees them weekly.
Speaking of the whole team, the paper spends a good amount of time on extracranial carotid disease, comparing carotid endarterectomy, CEA, and carotid artery stenting, CAS.
This is an area where the volume-outcome relationship has been debated for years. What did this review conclude?
The authors state that the association with higher procedural volumes and improved outcomes is reinforced here as well. High-volume surgeons performing CEAs have significantly better outcomes. They actually use the term clearly delineated in the literature. It's not just a trend, it's a statistically significant association with decreased mortality.
Let's move to ischemic disease, specifically mechanical thrombectomy, or MT. This is perhaps the fastest-growing area in our field. With the proliferation of thrombectomy-capable centers, what does the paper say about volume there?
It's consistent. The study notes that higher institutional case volumes for mechanical thrombectomy are associated with decreased mortality and improved functional outcomes, specifically looking at the Modified Rankin Scale, or MRS. They point out that maintaining high-volume standards for endovascular care is vital to ensure high-quality outcomes across different intervention modalities.
That's a crucial point for residents to hear. There's a push to get these procedures out to more centers to improve access, but this data suggests we have to balance access with expertise. If a center isn't doing enough volume, the patient might get the procedure faster, but will they have a better outcome? According to this review, maybe not.
Exactly. And the paper doesn't just stop at the operating room or the angio suite. It looks at the back end of care, the neurointensive care unit.
I'm glad they included that. We often say that a great surgery can be undone by poor ICU care.
Very true. The review demonstrates that the integration of neurocritical care has significantly improved outcomes. Specialized neuro-ICUs have shown reduced mortality rates and shorter lengths of stay for patients with both hemorrhagic and ischemic stroke.
It's that multidisciplinary approach the authors mention in the introduction. You need the microsurgical expertise, the endovascular expertise, and the specialized neurocritical care all working in a high-volume environment.
The authors actually conclude that this relationship between institutional and provider volume and better outcomes is so well established that it should help set the standards for care. They mentioned that maintaining high-volume standards for endovascular and microsurgical cerebrovascular care can help ensure high-quality care across centers.
For our medical students listening, what does this mean for your training? It means that where you train matters. Being in a high-volume center exposes you to the normality of complex cases.
And for the residents, it highlights the importance of the cumulative experience. The paper uses the phrase procedural volumes impact patient outcomes as a baseline fact. It's an argument for the regionalization of care for the most complex cerebrovascular pathologies.
Let's dive a bit deeper into the intracerebral hemorrhage, or ICH section. Often, ICH is seen as the forgotten stroke, because for a long time we didn't have many surgical interventions that clearly moved the needle. Does the paper suggest volume matters for ICH management too?
It does. While the snippet we're looking at focuses heavily on the specialized units, it categorizes ICH under the umbrella where comprehensive care by experienced providers is essential. The improved outcomes in specialized units, lower mortality and shorter stays, are a direct result of volume-driven expertise in managing the complications of ICH, like intracranial pressure spikes and secondary injury.
It really comes down to the systems of care. This paper isn't just saying be a better surgeon, it's saying work in a better system.
Exactly. To recap for our listeners, across aneurysms, AVMs, carotid disease, and thrombectomy, the data shows that high-volume centers and high-volume surgeons achieve lower mortality, fewer safety indicator events, and better functional recovery.
And don't forget the MS component. Even with the rise of endovascular therapy, as they put it, microsurgical clipping remains an essential skill that must be maintained at a high-volume level.
It's a call to action for the field to prioritize these high-volume standards to optimize patient care for both hemorrhagic and ischemic cerebrovascular disease.
Well, that's a perfect place to wrap up. A big thank you to Dr. Wolf and the team for this extensive review. It's a great reminder that in neurosurgery, experience isn't just a number, it's a clinical outcome.
Thanks for joining us on the Neurosurgery Hub podcast. We'll see you in the next episode.
Until then, keep learning and keep practicing. Out.